Welcome to another edition of Health Solutions with Shawn and Janet Needham, where Team Needham discusses everything healthcare. I'm your host, Shawn Needham, along with my wife, who will be here shortly, and my tech team who are working behind the scenes to stream this, and I so appreciate them. Today, you don't want to miss out. We have Dr. David Crawford. He is an orthopedic surgeon with JIS Orthopedics in Ohio, and he is going to be discussing affordable cash bundled options for orthopedic surgery. You might be surprised. We hear all the numbers about how expensive surgery can be, even orthopedic surgery. I had a personal example of that with my son last May, when he fractured his tibia, a compound fracture, and local hospital here charged him $47,000. And there were all kinds of surprise bills and wasn't very transparent. They had no idea what the price was. So I contacted Dr. Keith Smith a few weeks later and asked him what his price would be. Dr. Keith Smith is the co-founder of the Surgery Center of Oklahoma. We talk about him often here, and he is a cash surgery center there that works on bundled pricing. Also, his price was $8,000. So Dr. Crawford's going to give us some examples of how there are big differences in how you can find affordable health care, whether it be a local hospital or whether it be a surgery center like his. There's a big difference in pricing. It's important for consumers to shop around for price. So, and quality, and he's going to talk about that too. So, Dr. Crawford, welcome to our show.
Well, Shawn, thank you for having me. I look forward to it.
Yeah. So tell us a little bit about your surgery center, and tell us a little bit about yourself. Then we'll get into some of the specialty cash bundled pricing that we were discussing.
Sure. As we were talking about offline, I had a little different path than most, probably to where I am. I joined the military through medical school, did my training in the Army, and then served 4 years after that. So really got to experience true government healthcare, and then did fellowship after the military at JIS Orthopedics, where I stayed on. And our practice here for many years was just joint replacement. So Dr. Lombardi, Dr. Mallory is our founder. He has since passed, but Dr. Lombardi carried on after that. And Dr. Barron, for many years, were just the two here doing joints. Then we started expanding, doing more sports stuff. I brought in some sports for my military career. And then we brought on a spine surgeon and recently a hand surgeon. So we're growing. We don't want to get too big, but we bring the breadth of that. And the surgery center that opened in 2013, White Fence Surgical Suites, was really the baby of Keith Barron, and building into the outpatient joint space. And at that time, it was a very novel thing to do. People were poo-pooing it. Everyone said their patients weren't healthy enough to go outpatient. You can't do it the same day, but we did. And we did thousands and thousands, and we just passed, I think, 12,000 outpatient joints recently here. And we've shown how it can be done safely, and ultimately the patient experience is better. We have direct relationships with all the staff. We have some supervision over them, so when people are not performing, we have some input. And the staff here tend to enjoy life better, and that, I think, is transcendent onto the patient experience. And I see my patients a lot more. When I see them in pre-op holding, I can say hi to them. I do a surgery, they're in the PACU, holding area. And I see them probably 5 or 6 times. Whereas if I did it at a hospital, I'd see them in pre-op, and then maybe not to the end of the day if I did afternoon rounds. And with that, though, it's the ability to get lean and be efficient with both your economics of the center and also your time. And with that, then lends itself to a more affordable model. We're all aware that even insurance and Medicare reimbursement is less to the center. But the cost is significantly lower just to do a joint, just because the footprint of the center, the staffing that we do, and again the efficiencies. So White Fence has been around again for 8 years, and we kind of got into the more cash bundled market at a higher level within the past few years, but have been doing it somewhat in the past as well.
So Janet, welcome to our show, Janet. Welcome to your show. So Janet, do you have any comment for Dr. Crawford? I mentioned that our son had orthopedics experience in a local hospital here last year. Do you have any comments about how that experience was, based on how it might have been on in an outpatient surgery center?
Right. So our experience was really not that fun because, for one, we should have been more outpatient than what we were. And then, the care that you receive, and I'm not saying that the surgeon did a good job, because I believe he did. But just access to your providers, I think, is much different. So I really would like you to focus on how, I mean, you talked a little bit about it, but how much time do you say you get besides just you see them, but it is being able to explain the surgery and how they did during the surgery? Is that much different than when you're in the hospital? Because I think that's really what consumers want to know, is like, what quality is this going to make for me, and what outcomes are better? And I think, Shawn and I kind of see that, but the consumer wants to know the quality, because we sometimes have the misunderstanding that if we go to this big building and institution that we're safer. So why is it, better in your setting?
I think there's a lot to unpack there.
Yeah.
I guess I'll
Long
start
question.
with the long question, but I guess I'll start with the personnel issue. And I think, and I've listened to your podcast, I think everyone's on the same agreement that there's great people that work in the hospitals. There's great nurses, there's great
Absolutely.
surgeons, and I don't think anyone has an issue with that. It's the experience and the culture, and it's the bureaucracy that comes with large institutions that is ineffective to make meaningful change in a rapid basis. There are so many silos of oversight that if I have an issue, say a nurse is doing something wrong, I can't go directly to that person. I have to go up the chain here, down to the nursing manager over to here. Or if we want to change, a suture, you have to go to some VAC committee and whatnot. So because of the size of and even especially like an academic institution, we have at a surgery center one nurse that calls all of our patients the day before surgery. That same nurse typically calls all those patients the day after surgery. Mm-hmm. When you're in a big hospital, and that nurse who's calling probably never even interacted with that patient. They don't know who they are. So there's that lack of personal touch. Our surgery center is right above our office. We're very fortunate in that. And sometimes the staff will come downstairs and talk to patients in our office. And there's just that continuity of the personal touch. But ultimately, why we believe as surgeons the experience is better is because the accountability. And I mentioned that before. But we have direct change, and there's not a ton of us that are at the center. And if something's not going right, we can hop on a call in 5 minutes, make a change, and all of a sudden processes are different the next day. We want to change injections, or we want to change an irrigation solution or cement. It's a leaner way to make an effective change. To the safety issue, there is this false sense that your big institution has a lot of things that protect you. And people always say, well, how are you going to prevent blood clots if they do want to identify it if you do it as an outpatient at a surgery center? Well, when do most blood clots happen? They don't happen on post-op day 1 or 2 from total joints. They typically peak around day 7 and then again around day 28. So unless your patient was planning on staying in the hospital anyway for 7 days, you're not going to identify anything. The patient experience of getting labs drawn unnecessarily. We've looked at this and whether we even need to get labs. They're getting woken up 5 times in the middle of the night. Things that we historically have done that we know really doesn't impact the safety of it. And, probably the biggest, fear patients have is pain control, right? Because they're at home. Are they going to be able to control their pain? Are they going to get readmitted? Or the surgeon's going to get phone calls in the middle of the night? We have found that not to be the case. And we looked at a large series of patients. Only 0.3% of patients stayed overnight for pain control issues. So it's actually a very small percentage that has that need. So and then if you look at what we do, our surgery center is 2 ORs. It is all vast majority just orthopedics. We got a few ENT folks and plastic surgeons that do surgery on occasion. But we're not taking care of patients with pneumonia, with sepsis, with bad bacterial diseases. Yes, they may be separated on floors at hospitals, but the ORs are not having typically infected cases. So really, the scope of our patient base is a much healthier one. So that's we look at safety. I'd say probably number 1, 2, and 3 that we worry about in joint replacement specifically is infection. There's patient falls and all that sort of stuff, but we really want to look at controlling infection. So if I'm doing a case at the surgery center with staff that knows exactly what I'm doing, I could do a total knee in 25 minutes with open to the air and tourniquet up. Our hospital next door, I will be fully transparent, is actually very good because it was built as a specialty hospital that only did orthopedics, so it's not that much different. But when we go to tertiary hospitals that aren't there all the time, it is literally double the case time. And it's 45, 50 minutes that the knee's open to the world. And then there's a direct linear relationship of the amount of operating room time to infection. And then it's the people you work with. We don't work with those anesthesiologists as often. They don't know how to do the blocks consistently. And just again, the patient experience is different. So The quality comes down to, I think, a lot of oversight, a lot of direct input from the surgeons, having accountability from the team, and then all that does lead into the the synergy that happens that creates efficiency. Because efficiency is not us moving our hands fast; it is doing the least amount of steps to get the outcome that we need. And when you have a great team around you, you can do that.
So how can you have higher quality and lower price?
Well, we often struggle with defining quality. What metric are we using? And that's the price thing we'll obviously dive into, and that can be controlled by direct and indirect costs. But are we looking at infection risk as a quality metric? Sure. Are you looking at pain scores? Maybe. Are you looking at patient satisfaction with their experience? Did they like the staff? That's a different one. Are you looking at their range of motion 6 weeks after surgery, done at the center versus not? Are you looking at patient-reported outcome measures? That's a big thing, obviously, in our world of looking at patient-reported scoring systems. So the things that we can do to improve the quality aspect of that, again, is one, gathering that data, which is easier to do at our center. We use a app that all the patients log into. We can actually track. We can send them questionnaires, which we can't do at the hospital. We can actually communicate with them in messaging platforms via our center, which we don't do at the hospital. So that part of a quality experience is better. Already kind of hit on the infection side of things. And again, it's not that the infection rate is high at the hospital. I don't want to pose that, but that quality metric is better. Most of the times, patients, all they do is they see the incision. They don't know what you did during surgery. They don't know what really is inside, their hip or knee or whatever it is. They just know how they felt. And that's, whether it's seeing me in the office and I'm sitting down rather than standing up, whether I'm looking in them in the eyes, not staring at a computer. That I think drives a lot of a patient perception of quality from that respect, but then also just tracking data and being realistic about your data. We both at the center and in our practice, track all the time. What is our 30-day readmission rate? What is our revision rates? What are our pain scores? Any readmissions? And we are very active at keeping those as low as possible. And that hurt us when we were looking at the bundle payment with Medicare. We were already so efficient that they couldn't give us a bundle that we would actually have any room to make any money. It's amazing seeing compared to the other groups. So it's great for us. But those steps are all driven to a quality metric. The cost part is being competitive. I think the harder part is communicating that quality outcome with patients on a scale by which they can understand. And that's the difficulty. If you look at this, say free market, a true Travelocity model where we just have a list of prices, what scoring, how many stars do you use? Is that what we're going to go by? Google reviews? Are we going to actually post a whole complex spreadsheet of different metrics that they want to see? I don't know. And that's where maybe it's, look at some of the third-party companies we work with, where it's more of a travel agent model, where the travel agent has a little higher touch on each of the practices and can spend some more time talking to patients, where they still have a lot of options, but this place is $1,000 more. However, if you look, their revision rates are slightly lower, their infection rates are slightly lower, and let the patients and or their self-insured business, which is most of where this falls in our purview, make those decisions.
So will you back up a little bit on the Medicare thing? So you basically got penalized from Medicare because you guys were more efficient. Is that what you were saying?
We didn't get in the bundle. So, when BPCI came out, they do a historic run, and all the conveners, kind of organize this. And there's a bunch of different conveners that would run these models. And I forget the exact number, but let me say ballpark, our practices average total cost of care. So they take in, SNF utilization, physical therapy utilization, which are the big post-acute numbers that drive that up. And they create a historic number. And then your bundle, which you get thrown into then, is based on that and with a goal to decrease it. So we were something around like 19,000, I think, from a historic model. Maybe it's a little bit less than that. The hospital that is down in Athens, Ohio, which one of our partners works at, we don't do really cases there anymore, their bundle price was going to come in at $28,000, for the same surgeries. So we hadn't really nowhere to move down, and there was a number of other reasons why we didn't jump into it, because they didn't cover partial knees. We typically do knees 6 weeks apart. If we're doing both, then you have 2 knees under a bundle. But ultimately, our room for error for improvement to making it financially meaningful, with all the headaches that would go along with it, and then also waiting a year and a half to get paid on the upside, was just not there. So it was kind of incentivizing really low efficiency places to get enrolled and just try to make a little bit better. And those that were already efficient, there was no bonus of, hey, you guys are doing a great job, let's just pay you more because you are doing a good job.
That's interesting. You know, how some people for being inefficient can actually be rewarded for it. That's kind of how a government system works sometimes, huh?
Well, when I was in the military, we were judged by our OR utilization, which was the amount of time that the patients were in the operating room. So if I want to be the most efficient or most productive surgeon, I would bring a patient in the operating room at 7 a.m. and I wouldn't leave until 3 p.m. And I would do one case and I would have 100% utilization. And that would be the best metric of anyone in the system. Whereas if I knocked out 3 total joints and was done by noon or 11, you underutilized your row. So it's very backward metrics by which the government sometimes evaluates things.
Right. So were there surgeons that took advantage of that and they would stay in surgery 6 hours to meet
No,
those
I don't think
numbers?
intentionally. I mean, there's some folks that
Right.
weren't very efficient, but I mean, then it gets to some other incentive models, and I got paid the same when I was doing 6 cases a day, and someone else was doing 1. I would see about 30 patients in the office, and I had a partner that would see 5. And
You
the
got paid the
staff
same.
got paid the same, and the staff was there from 7 to whatever it was, regardless. If you started running late, anesthesia would just cut your OR time, so that case is canceled because we're not going over this time frame. People were just clocking in, clocking out. And again, there was very good people, and they're just incentives weren't aligned to behave any differently.
So that's why in a surgery center, at a free market like your surgery center, when you're competing with bundled pricing and employers that are looking for less expensive options, you can't get away with stuff like that.
No, and it's we've had a lot of discussions, and again, looking at what is the true cost of doing these surgeries and what is an appropriate margin. And there's been studies when there's surveys sent out to patients. What do you think your joint surgeon gets paid for a total knee replacement? And most people come around $10,000. They think what we get paid, and it's it's not a big mystery. You go on Medicare rates, and it's about $1,300 or a little less, and then you got 50% overhead for practice or whatever else you're doing. So it's not that we're not making anything, but who's doing all the work. And when the centers, and that's why it's important to have physician alignment with the centers and physician ownership, because then there's mutual benefit. When I'm dealing with these folks traveling, I just talked to a patient from Idaho who's going to have a knee replacement. They're a self-insured, part of a self-insured employer group. The price that we are going to be charging is half of what they would be getting locally. But it takes me a lot of time. I'm reviewing their medical records in advance. I'm talking to the patient. I'm making medical decision making. I got a lot of staff I'm paying to help coordinate all this care. And where we found kind of the bundling model being beneficial is running it through our practice and then back out to the center, where obviously the Surgery Center of Oklahoma is more of a center-based relationship and kind of paying down to the surgeons, which can work just fine. But in the end, who's doing all the work? Who's taking the brunt of the risk exposure? Typically a center is not getting sued if there's a malpractice claim unless it was something directly related to the center. So I think repositioning the incentives to the surgeon can bring more into this market. And I'd rather do less joints and do them have more patient interaction time. I don't if I could drop down to doing half the joints and making just as much money, I don't need to make more, but to be able to have that experience with the patients would be great.
Well, I also think it probably gives you more incentive as a provider too to have good communication skills with your patient, because I think that sometimes lacks in a big institution, that we don't get to connect with the patient like we should or could. And the other comment I want to make is, everybody's experience is different. A 18-year-old boy with a surgeon or surgery is going to have a different outcome than an 80-year-old lady. So the cookie cutter doesn't fit. Jordan probably had 20 more questions than my mother would. And that would be just partly their personality. She was a nurse and he's a young kid, so that opens your world up to actually being, interactive with the client and the patient. So the outcomes, I believe, probably are going to be different with those interactions.
Yeah, and I think this also, it puts onus on me as a surgeon to, I'm selling myself. I mean, when patients have choice, right. I mean, granted, our patients do have choice if they have commercial insurance or Medicare. I don't, can't say they don't. But when someone's shopping around, and I really look at it through a concierge lens. People are, if they're traveling, especially, and they're taking their time to do this, I want to give them the best experience possible. And just my bandwidth is only so wide. I couldn't do that with every patient I see, in its current state. But being able to sit down and answer those questions, give the patient extra time, The folks that do travel in, I call them more often than my other patients and check up on them, especially when they're back home, because they're probably scared that they're not right around the corner and they can come in our office if they need to. And it's been a wonderful experience. I just get to know the patients better, know more about their lives. Sometimes we'll have 20-minute conversations on our way home when I'm leaving work, and it's very enjoyable.
So speaking of enjoyable, what is one of the most dramatic or enjoyable cases that you've had that really just made you realize that you're an orthopedic surgeon?
Oh gosh, well, I can go way back in the. The most gratifying absolutely was my time in the military. Taking care of these amazing guys, and I was at Fort Lewis for residency, and they had the 275 Rangers there, first group Special Forces. When I was at Fort Campbell, we had a 101st Airborne, 5th Special Forces group, and then 160th. And it's a different experience than now. These are yes sir, yes, no sir, will do. Great patients. They, it was tragic to see some of the injuries, and I see a lot going on right now. I'll bring back a lot of memories on that. But they're so motivated, and you do a surgery on a guy, and one of the team guys from 5th group, like, well, can I deploy next week? No, you got to wait.
Wow.
So that from I think experiential aspect of my life was the best patient group. But we were talking about this before. I'd say the most dramatic surgery I do to this day is hip replacements. Patients with hip arthritis are miserable, and typically within 1 or 2 days after that surgery, they're not perfect yet, but they're so much better. And that is one of the biggest quality of life impacts that I can make on patients. Knee patients are a little tougher, but most hip patients forget they had a hip replacement by 3 months after. They're back to doing pretty much everything they want to do. And I get more, you've changed my life. I haven't been like this for years for my hip replacement patients. So as I was mentioning to you before, if I could just do that surgery, that's all I do.
Wow, that is cool. So tell us, what would a typical hip patient be? For your practice, what would a typical hip patient look like?
I'll tell you, it's changing. And, part of it's changing, I think, because I guess my tolerance and other surgeons' tolerance of doing them on younger patients. Historically, and we're getting the weeds a little bit of some, orthopedic manufacturing, but the polyethylene plastic back in the 90s and even 2000s was not the best. And so there were, those parts can wear out. And so if you're 50 years old, we'd like to put you off as long as possible. Some places had hard stops. If you're not 65, you're not getting a joint replacement. But with our changes in some of the manufacturing, our surgeries are less invasive. We're more comfortable with patients getting back to their life. We're not putting that off. So it is a breath. I got a hip replacement on next week at a 25-year-old, which is terrible, but there's no other option. It's probably one of the worst hips I've seen. And we got 95-year-olds. Same thing with all the joints. So it's a wider range. The median age still sits around 64.5 years old in joint replacement. But even the comfort level of doing outpatients in 80-year-olds, the age isn't as important as just their health, their home support. The conversation I have with patients, probably the typical more challenging one is like the 50-year-old. It's got a bad hip. They're like, well, I'm okay, but I'm not playing with my kids. I'm not doing doubles tennis that I want to do. I can manage by not doing all that stuff. And I'm like, well, listen, if I can get you back to doing most all those things, and when you're 70, we have to revise this. If I can give you 20 years of doing good, and it's probably gonna be just as fine after revise it.
And what's the recovery time for a total hip? I know it depends on the age and health of the patient, but on average.
Yeah, most of our joint replacements are done on the same day, outpatient or center. Even the ones done at the hospital, we still try to get folks to go home as long as they're doing well and have a good home support with them. Usually on a walker for a week or so. Some folks even less than that, and then get onto a cane. I think probably about 3 or 4 weeks is when patients see the biggest dramatic change, and they're just kind of ditching all the assistive devices. I just talked to a patient I did last Wednesday, and he was off narcotics by Sunday, that's another drive we're going down to minimizing that. But most all patients walk in our office at 6 weeks, feeling good, not really having too much issues at all and pain. And but if you say get back to everything, it's probably more 3 months, and that's really just patient specific in their demands and what they want. And if they're working at a desk job, they can get back sooner. But if they're in a manufacturer and standing and they don't have the ability to take breaks as much, then they may be more toward 3 months.
But still, that's considering how debilitating a bad hip can be. I've heard patients that have had it and they've suffered with it for years. 3 months is not that long to wait.
No. The most common thing we hear, again, more so after hip replacement, is I wish I would have done this earlier.
Yeah.
And when they've got both hips or knees that are bad, usually they don't wait as long for the second one to do it.
So what about knee? You said knees, they don't recover as well. Is that kind of what you were alluding to?
Yeah, it's something we've got our big annual meeting coming up, leaving tomorrow for San Diego, and it's the topic of all the, historically there's been 20% of knee replacements that, are unsatisfied or not as satisfied. And it's because, the hip joint is just a ball and socket joint. All we really need is the implants to grow in and then the patient's just to move, and there's not much functional kinematics that we're worrying about. Whereas the knees, although it's just a hinge joint, there's more complex balancing of the ligaments, trying to get range of motion back. It's much more important to have range of motion in your knee, and the hips are rarely stiff. And so it can be more of a challenge. And I think that's where, and patients do tolerate knee arthritis a little more, and they get to more end stage disease before they typically have surgery. So it is very important doing the right surgery on the right patient. And I think that's where probably a lot of those numbers historically on an aggregate registry level, it's, did those patients need surgery to begin with? Would there have been a better option? The caveat to the being is that I and our practice are a very big partial knee replacement practice. So doing partial knees, the most common is on the medial or inside part of the knee. And those patients do very well and pretty much akin to the hips. So about 30% of my practice, about 50% of Dr. Barron, one of my senior partners' practice, is partial knees of the knee practice. So that if I have to make one caveat, I would just do total hips and partial knees.
So partial knee is probably better than a total knee in most cases.
If you're a candidate. It's not the right surgery if you're not a candidate. If you got lateral disease, patellofemoral disease and lateral facet or no ACL, not the right surgery.
So what do you counsel your patients on, whether it be hip or whether it be total knees or any joint for that matter? What do you do before surgery? What happens if they are overweight? Do you counsel them on losing weight first and their recovery will be better?
And that would be the ideal scenario. We do not have a strict BMI cutoff at our practice. I know the Ohio State has I think 35 or maybe, I think it's 35, but maybe 40 BMI. And there's no question that the surgery is harder. The risks are higher. Infection is close to double in most of the studies. Wow. But then if you look at our infection risk we were 0.03% last year at the center. Double is 0.06%. Not that it's great that it's double, it's still very low. Right. And if you look at the change in quality of life in our outcome scores, obese patients never get as high as a non-obese, but they started much lower and their delta change is much greater. So it's really, if someone's 75 years old, or let's say 65, they've been obese their entire life, they've been way overweight, they're not going to, unless they're going to have bariatric surgery, which is fine, we send folks to do that, they're not going to change. And so it's, am I comfortable with their other health issues that I'm willing to take on that risk? I'm very frank with them. And if they, in the shared decision making, understand that, whether they truly understand that's a different question. They usually nod their head and like, yeah, I get it. Right. I don't know what it means to have an affected joint, but it is challenging. Whatever the patient's other health issues are, but I think it is sad to see some patients, and especially younger ones who are really overweight and they've been turned down by 5 surgeons and they can't function, they can't hold a job. At some level, I just don't think that's fair.
Yeah, that's a tragic situation for sure. So as we wind this podcast up, Dr. Crawford, our goal of this podcast is to educate and empower individuals to be in charge of their own healthcare. That also means financially. So how can you add to that? What would you say to patients when it comes to looking for orthopedic surgery?
The pure cash model is an interesting one because it's probably doesn't represent a very large portion of our economy and free market healthcare, if you will. It's mostly driven by the self-insured employers, which is about 60% of the employers in this country self-insure. But hopefully the patients are empowered to help make that decision and make a good decision. So I'd say the cost comes down to probably what is their what are they capable of doing? Maybe at some point they say, I only have 16,000 period and I got to find someone to do it for 16,000. Maybe they have a little more flexibility with their job. I would try or challenge at least the patients as best they can to, find surgeons with good reputations, groups that have been around for a long time who deliver quality care, whether that's getting data from their that group specifically and having questions. What is your infection rate? What was your dislocation rate for a hip? What's your readmission rate? Because more importantly for the self-insured businesses, that's a metric that they don't necessarily see when they're looking at just the upfront bundle cost. If you say, oh, it's $18,500 for a total hip, but that patient gets readmitted or goes to a hospital a week later, all of a sudden, I mean, who knows? That could be $50,000, $60,000, and depends on what their stop loss is, what they're on the hook for. So those are the metrics that's what we get vetted for when we're going with these groups to help arrange this. Is they don't want to just look at what our cost is. They want to really pull that data of what our overall episode of care cost is out 90 days and even greater, because these businesses are on the hook for it.
And especially outcomes. That's probably one of the most important, right?
Yep, absolutely.
For productivity of an employee if they're paying for it.
Yep.
So, okay. So, what do you have a passion for, Dr. Crawford? What drives you?
I think innovation. I'm very fortunate to be surrounded by very entrepreneurial and innovative senior partners who've led this field for a long time. Dr. Lombardi, I don't know how many patents he has, but designed many knees. They were innovators in the outpatient space. We're innovators in the partial knee space, anterior hip, outpatient joints, and getting into this. And it's just fun. I mean, I think joint replacement especially can get monotonous, although I love it all the time. It's just doing cool things. And that's where, being in a private practice, I'm afforded that privilege to go do that and be entrepreneurial. Whereas if your hands are tied in an academic institution, despite your best efforts, sometimes there's no reward.
Well, it's obvious that you enjoy what you're doing and you do have a passion for it. I was really surprised when you said that you could do total hips all day long, because I know doctors in hospital systems that despise doing total hips. So I don't know.
Send them my way. I'll do them for them.
Yeah, right. I don't know if it's a system they're in or if it's a personal issue or what, but that's really reassuring that you really enjoy what you're doing. Because if doctors don't enjoy what they're doing, then they're not going to do a very good job at it. That's my opinion for sure. And I think there's been a lot of studies to show that too. So Dr. Crawford, what is the best way if anybody has questions or they want to get a hold of you? What's the best way to find you?
Sure. Our website is jisortho.com, and you can get some information there about our practice. If there are employers that want to get in touch with us too, you can certainly do that. Phone number is 614-221-6331. And those are the two direct ways. And anything bundle related, everyone in our group knows to hunt me down, because I've been running the show for a while. And certainly look forward to taking care of any patients out there that need help.
Awesome. Well, thank you so much for being on. I really, really appreciate it, Dr. Crawford.
Thank you.
All right. You've been listening to Health Solutions with Shawn and Janet Needham. Tune in Wednesday morning. I will have fellow pharmacist Ben Fuchs on, and he will be discussing how to keep your immune system healthy, along with some other things. We speak the same language, and if you've been listening to me long enough, you know that I'm kind of a renegade pharmacist, and I don't really, Jen, I don't embrace traditional medication. We embrace lifestyle changes, and so does Ben Fuchs. So you don't want to miss out. Wednesday, 8 to 9 a.m. Dr. Crawford, thank you for listening. Okay, thank you for your podcast, for joining us today. And listeners and viewers, thank you for tuning in. You've been listening to Health Solutions with Shawn and Janet Needham. Thank you.